All right, we will get started. Hi, everyone. I hope that everyone is having a great day. Welcome to today's presentation. Utilizing cost data to drive programmatic change is the fourth and final part of our webinar series offered through the Delta Center for a Thriving Safety Net. The full series entitled Understanding Your Costs in an Evolving Payment Environment has been developed by Capital Link with input from JSI, and I'd like to thank you all for joining us today. The Robert Wood Johnson Foundation and the Delta Center for supporting this effort. You can access recordings to PowerPoints from the prior webinars in these series on the website of Capital Link and the Delta Center. Today's webinar will be recorded and posted on the website as well. Today's presentation will last 50 minutes with 10 minutes for questions at the end, but feel free to ask questions throughout the chat box located in the GoToWebinar toolbar on the right-hand side. A PDF copy of today's slides will also be available for download through the handout section of your GoToWebinar toolbar, as well as on our website. Today's speakers are Dave Kleiber, who is our project consultant at Capital Link, and Bob Urquhart, consultant and retired FQHC CFO. And with that said, I'll turn it over to Dave to get started.
Great. Thanks, Chloe, and thanks, Bob, for joining me again on this presentation. And I'll echo your appreciation of the Robert Wood Johnson Foundation and JSI for their assistance in helping us put this together. This is the fourth presentation of this series in Understanding Your Costs, and this is the one where we're going to talk a little bit more about we'll review what we've done before, and then we'll move forward and talk about how you can use the information you're going to develop using some of the tools we discussed to make different programmatic decisions, especially moving forward in a value-based payment environment. Okay, I'm going to change over to move the slide. Chloe? Thank you. Okay, so we have 3 sessions before this. The first one was cost allocation, getting the basics right. That was done based on a product we did for an update for NAC, which is original was back in the early 2000s, and it basically cost per visit analysis that walked through each of the steps that you would need in order to figure out your cost per patient, cost per visit on a very high level. Bob, you want to talk about second?
Okay, yeah, and good afternoon, everybody, and welcome. On the second session, we talked a great deal about how to prepare your internal systems, specifically general ledger, chart of accounts, the detail level you had to go to if you wanted to be able to track information by program or by department or service line, and also how to take the electronic health record, your payroll systems, and the general ledger and bring those all together to give you the data you need to put together a very solid cost foundation for your business.
And then the third session we did was on understanding the cost in an evolving payment environment, which was drilling down a little bit more to figuring out how to do a capacity cost analysis. And we're going to do more of that today, trying to get to where you're not using averages so much, but you're focusing more on a time-derived costing, which will be more useful when it comes to programmatic decision making. Next slide. So Bob, where have you heard this phrase before? Your costs are your costs.
Yeah, that's my very eloquent way of saying that. The point I'm trying to make with this and these 3 bullet points is that regardless of what you get reimbursed for, regardless of what your fee schedule says, you need to be able to identify and capture all of the costs that are related to providing services by service line, behavioral health, and dental, or whatever you may have. Being able to capture all of those costs, regardless of whether they get reimbursed for them. Then, the next couple of bullet points basically say doing that will allow you to make more prudent business decisions. When you need to decide where you want to make programmatic changes or you want to reduce costs, knowing where your costs are, knowing where your high performers are, knowing where your low performers are, help you be more specific. My analogy is you can either hunt with a high-powered rifle, take one shot and take it out, or you take a shotgun, hit a whole bunch of stuff and not kill anything. I think not having the detail to be able to laser beam in what you want to hit makes it more difficult to make good decisions. So this is all aimed at helping you get there and knowing what the trade-offs are to get there.
Okay, next slide. We're going to spend a few minutes on this slide. You may have not seen this data presented before, and the point of putting this slide together is to try to convince you, if you need convincing, how important it is that you do get an understanding of your costs as an FQHC, perhaps more so than anyone else in the private sector in the healthcare world. So what this graph represents is it's all UDS-based data. You take your health center cluster grants, all of them together if you're a multiple grantee, and you divide it by the number of uninsured patients. So at that point, you've got the amount of your grant, and we all know that at least on a theoretical basis, the grant was meant for us to cover our uninsured, the costs of serving our uninsured. So you have that number, and you take that, put that over the total cost per patient. All right. So if hopefully that's clear. You've basically got how much of your grant, how many of the uninsured are you covering with your 330 grants, given your costs. All right. And where those two lines intersect is where that ratio is 1.0, which means you're theoretically getting exactly the amount of money you need to cover the cost of the uninsured. Now that's all costs. This is quite a high level, very generalized analysis. But the important part is to think about all the centers that are to the left and to the right, and you're all on this chart at some place. Every one of the little lines, which are almost impossible to see, is one of the 1,300 health centers out there. So if you're to the left of that line, that means that you're basically looking to other programs to subsidize the cost of your covering the care of the uninsured. So your grant does not cover the average cost of care for the uninsured. Well, if that's the case for you, and that's true for some of the much older centers who've been around for quite a while, but and in certain states, and I'm going to guess primarily states that did not expand Medicaid, and therefore have many more uninsured than some of the other expansion state centers. If you're one of those centers on the left, then you really need to understand what programs you have that are making you money, right? Because you rely on them not only to cover their own costs, but to cover some of the costs of the uninsured and caring for the uninsured. If you're over on the right, which is the majority, you can see the numbers down below. There's 790 of those as of 2018. Some of you are making multiples. Your grant covers multiples of the cost of care for the uninsured, which is it's a great thing. I mean, it's a nice subsidy to have. But what can happen is, because you have that subsidy, if you don't recognize it, you may think that you're doing fine in the fee-for-service world or the PMPM for world you're in now. But in fact, you're at risk because you've got too much of the HRSA grant covering general expenses and other expenses of the center beyond what they were really intended for initially. And so you get to that those folks are out there at the 3.0 and 4.0, and you can see how the graph goes. It's almost like there's a potential for a little laziness in analytics. Do all our programs actually make money? And that's not a mandate that they have to, but you should at least know if they do or not. You may not. You need to know that one way or the other here, because things can change. Especially take the current environment with the COVID. How many more uninsured are suddenly going to show up at our centers? They may be your existing patients, but they lost their employment-based insurance. All of a sudden, our payer mix could potentially change quite dramatically. So hopefully that's clear. Next slide. Chloe, next slide. Hello, Chloe?
Hi, Dave. Yes, we can hear you.
Yeah, can you move the slide, or I'm not?
There we go.
Thank you. Okay, so you've seen these next two slides already. We're going to go through them fairly quickly. There are two ways there's ways of looking at the value-based payment systems, and they're basically a three-layer approach. All of you are working with some type of base payment. Some of you are actually still in what we might call layer 0, which is a pure fee-for-service world. But many have moved on to a base payment involving a per member per month payment. It's capitated, covering more of the costs of your patient care and giving you a little bit more flexibility, so that you can use some of that money that you get in order to pay for enabling services that aren't directly reimbursable. And that could be under the structure of an APM or just under your a PPS, but a per member per month structure. And then you've got two other layers above it, which we talk through. The patient-centered medical home, which many of you are, is the first layer up, which is, hopefully allowing you to do more care coordination, excuse me, and infrastructure development, such as HIT. And the last one is kind of what we're going to focus on today and talked about a little bit about the last time, which is including shared savings, some type of population-based payment, and some kind of reward shared savings type of arrangement in order to kind of incent you to focus on your patient outcomes. And with that, to be rewarded for good patient outcomes based on measures that you've agreed to with your payer. Okay, next slide. Great. So this is the same basic information, but just pointing out that this is shared by the view from HCP LAN, which is the healthcare payment reform group that sees the world pretty much in the same way, so slightly different, and breaks down a little more detail at the third level. But this is work. This was pointed out and work done by JSI, and it pretty much is consistent with what the NAC model was from 2014. So we're going to be talking now. This session, we're going to be talking much more at that third level. Next slide. All right. So in order to move forward to into this, we're going to flash back to the first session that we talked about. I'm going to do this a couple times here, where we're just trying to remind folks that regardless, this a bit relates to Bob's comment about your costs or your costs. You can slice them and dice them in a variety of ways, but no matter how you approach it, you're still going to break them down primarily this way. So the provider costs, direct support costs, direct enabling costs, overhead, and then ancillary costs if you have them. So this is important because even though we're gonna show how you can do capacity cost analysis, which is a little bit different than that high level cost we were doing before, we're still going to end up needing to have our costs broken down into these buckets. Okay, next slide. I'm gonna start this off and let Bob have a few words here. This is the key to what we're doing now is that we're going to talk about the actual use of the resources, not in a generalized, here's all our costs thrown into this bucket and here's all these patients thrown into another bucket and we do the math. We're going to talk about trying to determine using time and on the optimal level, thinking about this on a per patient basis so that we could, in the perfect world somewhere in the future, we'll be costing all our patients individually. I don't think anybody's ready for that at this point, but that would be where we'd love to be able to get. And that will be required, that how much time is required in order for us to actually serve that patient. And how do we calculate that based on who's in the room, whose services are needed, what other resources are available and required from the health center, both facility and enabling resources, and then the support costs. Bob, is that anything you want to add to that?
No, I think the challenge here is when you look at trying to get to this level, it can be done. A lot of us already have the ability to do it in our payroll and human resource systems, but it's going to require a different look at those systems and a different discipline to get to that level that we want to get, ideally you'd like to get to. So when you look at this, I don't want everyone in the audience to be saying, oh my God, this is not possible. It is possible, and it will take some work to set up, but if with the right setup in the payroll systems and HR systems, we can get here.
Great. Next slide, Chloe. Another flashback. So here's what we talked about just a little bit ago and in the earlier series, is using those historical average costs. So that's that high level that we were talking about. You get it off your UDS, so you can kind of come up with some generalized, universal, if you will, patient cost per patient on a variety of levels. You can drill down, as you know, fairly down to a fair amount, but it's not going to get to a patient cost anywhere close to a per patient cost for any individual. And part of that is because everyone who comes into your health center kind of approaches you, presents with different needs. And so one of the ways to deal with that is to, and this is again, we touched on this in session 3, is to stratify those patients by the intensity of needs. So if you've got a lot of chronic care patients, if you have a lot of well child visits, if you're in an area with a lot of high Medicare population, have a lot of frail elderly, you may want to try to work with your clinicians to think about grouping those patients and the care of those patients into kind of clinical pathways. And that's what we talked about last week, is the development of costing mechanisms for clinical pathways. So there's a clinical decision to be made there, and then there's a costing that goes on with that. And so what we'll move on to the next slide here, but we're going to keep that thought in mind. Okay, so Bob, you want to take it from here? These are the slides that you put together on Greater Lawrence's actual experience in this, trying to do something similar to this.
At my former health center, like all health centers, the challenge was how to provide behavioral health services in a health center environment. So we try to look at many different ways to go through it, and we developed a couple of different models. I would say semi-successful, and you'll see the numbers in a few minutes. But I think that the key to this was being able to identify and track all of the moving parts of the costing of the behavioral healthcare system. If you move ahead to the next slide. So this slide basically says, when we set out to do behavioral health, the left hand, the hours per week, rate per hour, and the annual total, we identified the positions that we'd want to have. And so you get on the left-hand side, clinical psychiatrists, behavioral scientists, et cetera. And we started out with a very small presence in that initial pass, and that had about a $700,000 price tag in terms of cost for the salaries of the people involved. We did this for maybe a year, and then we decided we would try to expand it. And expanding it basically meant pretty much doubling it. We wanted to put a presence on all of our sites. So the last 2 columns on the right show what the impact of that was when we said, okay, we need to do more of it and put it in more sites. We had a significant increase by almost 1.5 million on the salary side to develop that presence. The next slide, which kind of spills over from this, takes each one of those and says, based on, am I still with you guys?
Yeah, go ahead.
Okay, so I lost the screen, but it's okay. Yeah. But anyway, the next slide says that based on that mix of people, here's how many hours per week and how many weeks that they would work. The patients per hour, which is very low, 1.25, we were hoping to get there, but in reality, we were barely hitting 1, which for many, many reasons. But so we calculated the number of visits we expected, and then we used the revenue per visit, which was right off of the fee schedules from Mass Health, which is our Medicaid, and also some private payers. So we come up with what we expected for revenue. A couple of people like behavioral scientists, those were positions that were teaching positions. They were there to help our psychiatrists and help some of our residents learn how to do this. So they weren't a billable service, but we had them as part of our mix. And then the community workers and the medical assistants. So that was kind of the model, and that was how we built to drive the revenue.
And I think anybody looking at those RPVs there in that second to the right column, and comparing it to your PPS rate at your particular health center, you can see right off the bat that, you know, this is not untypical for behavioral health systems across the country to be really effectively under reimbursed.
Right. Yeah, I think the key thing is I'm showing you what the world is in Massachusetts. I mean, you could have different numbers, but I guess the message is to do that kind of grid and to do that kind of chart to say, here's what I can expect, and based on reimbursement rates, here's what the revenue would look like for my patient services. And on the next slide, essentially we're just going to run through what the income statement would look like. So on scenario one, which was the real stripped down entry level, and we expected 8,700 visits, 5,700 total patients, and the revenue 582,000 included a small grant that we had managed to get to help to do that. Move over to the next column, and we did scenario two, and we did scenario two on the premise that there would be available pay-for-performance money. We had been led to believe that, and some payers dangle some stuff out there for us. So we had been led to believe that taking this jump would allow us to earn some additional funding, which it did. The $100,000 you see on here is an estimate. I don't think we ever really fully achieved that for many reasons, but we did get up to these numbers. We did have about 1.2 million in operating revenue. And then on the third column was we kind of scaled back to the original, and we had a smaller paper performance, but you can see the revenue was 632,000. So in any scenario, we didn't have what you would call a significant revenue stream. If you go to the next slide, this is the other side. This is the expense side to it. So scenario one, the stripped down version, we showed you that a few minutes ago. You can see what the costs were. Total operating expenses of about 791,000 before we allocated overhead and other costs. So that scenario, the health center was in a deficit position of about $422,000. When we went to scenario two, the deficit grew a little bit, mainly because we had more expenses and we saw more visits, but about the same ratio. There wasn't a significant change. So we then said, you know, we need to rethink all of this. We kind of scaled back. We ended up somewhere between these two. But the point that I'm trying to make to all of you is that in the environment you're working in, depending upon the reimbursement, I have not seen a behavioral health program in Massachusetts anyway, where the numbers are much different to what I'm showing you here. I know specifically 5 health systems I've worked very close with. These numbers of deficits between $300,000 to $600,000 are very common. So the challenge for us is how to take that information, and we'll a little later on in our presentation today, how to utilize that to improve the revenue side.
Okay, next slide, Chloe. Okay, so we're going to take a slightly different approach now moving forward on this. The first, we're going to have a behavioral health example. We're going to follow that with a medical example, and then we're going to talk about what potentially you could do if you integrated those. And the idea here is to suggest that the behavioral health on its own, excuse me, without any value-based payment, and the medical side on its own without a behavioral health element, you know, not integrated, work in a certain, you know, cost structure and a certain profit, you know, programmatic profit structure there. And then there's a realization at some level that perhaps behavioral health metrics for value-based payment systems are not quite as clear and as, you know, numerical and easy to, no, I won't say easy, but easy to identify and maybe not easy to achieve as in the chronic care world or in the medical world. So really the reason that you're trying to create a different kind of a program with behavioral health integrated into your medical is because it actually, as we all know, will provide benefits to the patient. But those benefits might actually be reflected on the medical side. Their chronic care metrics might actually improve because of behavioral health care that you're giving. And so neither of the two programs on its own might measure out, but if you look at it from an integrated basis, you start to see some of the benefits, and you start hitting some of the numbers that you want to get in order to achieve the value-based payment that's available. So if you were with us the last time, we put together a chronic care scenario on a clinical pathway for diabetes. And in that, we pretended we were in a value-based payment system whereby there was a payment threshold, effectively. If you hit the metrics, and we'll talk about that more after this set of examples we talk about, is how the importance of getting involved early with your payers in the establishment of those metrics, which ones you use, what the numbers are, being sure that everybody's on the same page as to what you need to actually hit. By assuming, that threshold has that you can hit a percentage of the payment of the patients that hit those thresholds. So if it's 50% and there's no extra payment, but there's nothing owed, and we're assuming you're going into a world where there is some downside risk, and that's, as we all know, is fairly rare out there. Though we'll also, at the very end of the presentation, talk about a new CMS effort that's just getting started, which has introduced a limited amount of downside risk, but it's been long in coming. I mean, we've been, enjoying the upside shared savings, but, in the reality, this system was put together so that there was something to try to help control the cost side, and if you didn't hit your targets, that you actually was a financial penalty to it. So this model we're using here does that. It says if you're under that 50%, then you owe back $250 per patient. At 50%, as we talked about, there's nothing paid either way, and above 50%, then you earn $500 a patient. This is annually for every percentage of those patients over 50%. Next slide. Okay, so now instead of it's a little bit reorientation of the salary slide that Bob presented a little bit ago. Mostly the same individuals. But what we did here now is we said, all right, let's really drill down to the availability of this resource. You're thinking of staffing as a resource like you would any other assets you have at your health center that you use to create the patient outcomes that you're after. So in the first couple of columns, you're talking about here's some people who we all work under a 52-week structure, but not everyone obviously works 52 weeks. You have vacation, you have your CME. And so we've made some adjustments in there. Now, don't take any of the numbers in here as some kind of gospel or, this is the way this is supposed to be done, or these are the correct numbers, or these are even the average numbers. These are just numbers put in there that you should put in for your particular people, that apply to the staffing that you have at your health center. That's going to change from these numbers, but the math doesn't. So anything in a colored, kind of shaded column here is a number you input. The rest are calculated. So you get your net full-time weeks available per year, just you're doing the math, which becomes a certain number of working days. And then you have a certain number of working hours per day, which could change depending on what your policies are. And the next column is interesting because it's your daily, what I call a daily availability factor. So as you know, not everybody can, if you're there for a 7-hour workday, they're not working 7 hours or not in front of patients for 7 hours, right? Everybody has other things that they have to do. They're in meetings with other providers. They're meeting with administration. They're between meetings. They're, whatever. There's a whole list of things that responsibilities people have, as well as just a little bit of downtime during the day. And so you got to adjust for that to some extent if you're going to come up with a minutes available per day. And this might be where you start to roll your eyes like, oh my God, minutes, we're down to the minutes level. But this is kind of the key to determining the capacity costs for the various staffing levels that you have. Because you then create the minutes available per year, and you go on to, and then we have a final column for their annual compensation. Again, those are just numbers we added. You'd obviously put in numbers that apply to your health center. Okay, we're not gonna, there's 4 more, columns in this graph. We're gonna start working with those 4 and not come back to this, but they all tie to this set of assumptions here. So you need to prepare this in advance. And then we go to the next slide, Chloe. Okay, so here's the kind of where we start to make the adjustments based on whatever our programmatic decisions have been. So I didn't point it out in Bob's slide, but the first scenario that he talked about had a personnel cost of $81.83 per visit. And so this was modeled at the same amount, just to so you kind of do an apples and apples thing. And it also, the important column here is that blue column off to the left, where you have the average time in attendance during a visit. Again, there's no magic here. There's nothing saying these are the correct numbers. These are just numbers we entered in to for illustrative purposes. But it does it'll vary depending on what your program strategy is. You might get, if you're going to bring in new team members, including some of the folks down below, and we'll get there in a future slide. This one is about behavioral health only. So you're seeing the psychiatrist for 15 minutes, and then you're going to see, in this case, the therapist for 20 minutes. And at the same time, they're going to also be seeing some of these other folks. They may be at this clinic more than an hour, obviously, but each of these individuals is only seeing them for a certain period of time, and they can move on to the next person. And you want your high cost, high licensed, if you will, people having that flexibility to do that. That's how you generate your higher productivity rates, which are important even in a PMPM world. So going back up, you got your visits per year, which is your productivity rate that you can calculate based on how many minutes you are potentially going to stay with those folks. Now, granted, this is, each individual patient, if we brought them down to, Joe Smith level, would differ. But we're going to say that for this group, that's the level we're going to talk about. We're going to assume that the average visit of each of these types is the numbers we put in there. So then you can use the salary number we had from the last slide and come up with their cost per minute and cost per visit. And that's how, using those math, is how we came up with the 8183 in the far right corner. Okay, next slide, Chloe. Okay, so now we've got a more integrated approach. The medical column that you talked about will just be the top part of this graph later on. But here we're just showing you kind of what happens if we say, all right, let's make this whole visit they're going to see the family practice physician, and they're going to see this suite of behavioral health experts. So I'm going to pause and because I'm sure going through a lot of your minds here is that, oh, this looks great, but you're now up at $180.80 just for the staffing for this visit, for this patient for this visit. But does it assume that we're paid once or twice? Is this 2 visits in the world of our reimbursement, or is it 1? And in this case, we're going to make the assumption that you get paid for each of these, seeing the primary care visit and getting paid for your behavioral health visit. But we know that in fact is not the case everywhere in the country, and it's one of the big struggles that a lot of us have. But there's that argument's been going forward. Bob, you've had there's discussions in Massachusetts, haven't you, about payment for 2 visits in the same day?
Yes, we have, and there's been some movement, particularly in the behavioral health arena, because there's a lot of anxiety around that issue. So yeah, and some payers actually have moved that way, but it's a slow process.
Yeah, and it's obviously going to be key to making all this work. But it's if the powers that be are going to push, which is appropriately so, push the integration of behavioral health, we do need to get to that point where these longer visits, and you can see if you add up all the time, this patient's here at this health center for quite a long time, and longer than you would see in your normal 15-minute primary care visit. So that's just, this reflects your costs. Should also be reflected in what you get reimbursed. Next slide, Chloe. All right, so we're using the same revenue structure as Bob used for session 1, and here I've changed around a little bit the scenarios up above. You got behavioral health only, then your med only, and your integrated. And we're assuming that you're right at the 50% threshold for behavioral health and med. So there's no extra payment under your value-based payment system for this. But we are adding the visits up. So we're assuming there are those, as we mentioned, we're assuming there are you're counting the behavioral health and medical visits separately, but the same number of patients. And so you see walking through the down below the average revenue per visit is calculated. And so we're using, for medical, we're using something around $150 average revenue. That's probably high for states that have a high uninsured rate, because your PPS rate might be above that. Hopefully it is, but average, it might, it might not be that, but that's just to point out what we're doing here. And then on the combined basis, it comes down to about $109 a visit. Okay, next slide, Chloe. Okay, well, here's where we do a little bit of magic, and hopefully you don't roll your eyes through this presentation as well. But we did. This is how we did it in the diabetes session last time, and it's a similar concept here. But the idea is that it's only in the integrated example here in the third column that we get the results that we're after in the way of patient outcomes. So this session, we didn't talk about what those patients' outcome might be. In the behavioral health world, there are pages and pages of different lists of different kinds of tests and measures you can use to determine whether someone's making progress in the behavioral health world. And we're going to assume that you've made those measures have been established and they're relatively easily identifiable. But primarily, you're using the measures that you've identified for this patient group in the medical side. And because of that, you're walking down through these costs, which are consistent with how we had developed them before, and we're applying an allocated administration overhead, same amount that was used before. But in this case, we're assuming that you've got 85% compliance under your value-based payment, the same as we had set up the model. And, okay, I'm sure you're thinking, oh, imagine that, the numbers worked out. Well, because we made them up. And that to some extent is true. I mean, there's no guarantee that this is going to work, but it's just supposed to be illustrative. The math is correct. I mean, this is how you'd get $1 million annually for this group of 5,000 patients if, in fact, 85% of them hit their value-based payment and you were given $500 as a shared savings or reward payment, or whatever you want to call it. For each one of those over the 50% threshold, suddenly making that the combined programs here make sense. I mean, you can make money at it. Now, you're looking at them individually or as a department, you might think this doesn't make a lot of sense for us. What are we doing? We need subsidy. But collectively, assuming you can demonstrate that you are hitting those goals and making those patient outcomes, that this can work. And it's definitely out here waving the flag for integrated behavioral health. Personally, I worked as a board chair in a mental health agency for 10 years, where I used to live, this is near to my heart, this idea. And we tried, and it's difficult. There's no question about that. We tried applying this in reverse. There, we added a primary care provider to our mental health workforce. And found it was quite difficult to get the numbers of patients that we assumed would all flock to this doctor because it was more convenient for them. But it took a long time before we could really build our panel up to a number that wasn't losing money on that side. So we know this is difficult, and integrated behavioral health care is a work in process in many places and done differently in many places, but done successfully in many places as well. So that's the focus that we want to have here, that there is an outcome here for your patients, which is better, and for the center. Okay, next slide, please, Claude. Okay, this is just a quick slide. I'm not going to go into this in detail, other than to say we've been talking about numbers. We've been putting into charts. So, this is great. If we assume these people are involved and you track them, somehow magic happens, right? But in fact, there has been empirical work done on community health workers and the involvement of community health workers at various levels, team leading and team participating levels. And, they've been able to drill down to demonstrate either the cost savings or the improvement in outcomes. And so I'm not going to go through the details on this slide. You're welcome to look at it if you download the slides yourself. But it's good to know that, in fact, this isn't just, this sounds like a good idea. Let's implement it everywhere. There's been enough study done, and they're doing it on various interventions and different types of staffing to demonstrate that, in fact, bringing these people in. And this is related to, and we'll talk a little bit more about the social determinants of health, right? Your case management folks and CHWs who are out there working with people in their real world lives and trying to help them manage real world problems they have that aren't directly health problems, but do have impact on their health. Okay, next slide. Okay, so we're going to go through a little bit of this now. We're kind of moving on to now that you have an understanding of the power of what this value-based payments, and not just from this presentation, but from all of them. How do you approach negotiations with your partners? We'll call them. Of course, they're your payers, but they need to be your partners as well in all this. You can't be on the receiving end of or feel like you don't have any choice and have to be on the receiving end only of the payment mechanisms that are applied to your health center, right? Once these discussions begin with your MCOs and ACOs, you need to be an involved partner with them. And there's a couple of very key early on decisions you need to talk about. Patient attribution is one of the most important ones of those, right? And in the behavioral health integration world, it's even more important because you may get attributed patients that you don't know in a sense from your practice. So that's the great unknown, right? If they're all patients that you've seen before, you have a sense of their acuity, what they're going to need, and you can start building those clinical and chronic, those groups we talked about earlier based on the symptoms and their condition. But if you're getting patients attributed to you that come with the payment structures, that's potentially a good thing. It can be a little nerve-wracking. So you want to be able to have you're not going to necessarily have a say in that, but you do want to, instead of Joe Smith versus Jane Smith, you want to be able to have that discussion about the number of patients you're getting, their types of symptoms, their location, where they've gotten care before. Be involved in that process. The performance improvement in projects, this is something that every MCO has to do as part of their negotiation with their payers, especially on the Medicaid side, CMS. They need to be doing these performance improvement projects. And you want to be involved because this is how you can influence how the metrics that you're being paid for are set up. Do you have you developed something in your center that you find to be particularly effective, but the MCO doesn't really pay you for that, or doesn't recognize that that's a much higher cost, but your outcomes are really dramatically better? So that's where you can get yourself involved in a performance improvement project, working with your MCO in order to demonstrate that, in fact, you found a way or an intervention that works better. And presumably you've costed it, so you know that given a certain reimbursement, you can make money at this or at least break even. Then we talk about leveraging the Medicaid and managed care, health and ACO innovations. That's, again, a lot to do with patient-centered medical home and programs that have been put in place through your ACO that you can, you'll know those pretty well, get involved with them, utilize them to the extent that you can. And the last of these four that I'm going to talk about is social risk adjustment, which, again, this is not in place in a lot of states. Massachusetts is talking about setting up a social risk adjustment payment, but isn't actually paying under it yet. But there are conversations going on in various states, which just is a reflection, again, of the social determinants of health. Just not everyone approaches you, even with the same set of symptoms, in the same situation for their health. In other words, their ability to recover is different based on all the factors in their life that affect their health and their health recovery and their ability to follow the instructions, et cetera, that you're going to give them as a medical provider. So those are important elements to your payment system and your value-based payment analysis you need to be talking about early on, so that you're a participant in that and not just the recipient of whatever codes come down or metrics come down. And Bob, you want to talk about that last bit? That's kind of a little bit arcane, but it's important. Charge master. Bob, are you there? Okay, well, I'll pick up that bit on the charge master. So, are you there?
Am I back? I think
Yeah, there you go.
All right.
Okay.
So in my experience at the health center, the charge master was something we looked at every now and then. We set an office visit rate and said that's what it is, and we made sure that there was a gap between that and what the highest payer was going to give us, so we didn't get caught in the trap of getting the lower of the two. But a couple of years ago, because rules changed, we actually had our auditors come in, and our auditors came in and did a stratification of our charge master, and they actually helped us set those rates, taking into account all of our costs for all of our programs. So I think it's something that you have to make sure that the charge master reflects all of your true costs for all the services you're providing. And it's a big job. And like I said, we had the auditors come in and do it. Then we had a stress test the second year by a different group. I would strongly suggest that if you haven't done it, you do that, because that's kind of a key item to make sure that you have all your costs into your charge master.
And at the full cost of service. And that's, in order to
Yes.
be able to do that, you have to know what those costs are. So that's, again, another argument for going back and making sure that you understand what costs are involved in, each of these particular line items. Okay, next slide. We're going to go quickly through three concepts that we're kind of reiterating, so we don't need to spend a lot of time on these. But when you're talking with when you're negotiating with an MCO or an ACO, and you're talking about your value-based payments, besides the patient attribution, which we noted was a very important piece of this, how that's going to happen and what numbers you're going to get and what say you have in that. The clinical measures and metrics is equally important. You need to understand them. Your clinicians need to be able to be on board that in fact they can accomplish them, that they understand them well enough to be able to say, okay, that's in our population, in our area, that's a measurable metric, and we can hit the level that they've set as call it the 50% threshold, however that particular program is structured. Next slide.
Let me ask something to that.
Oh, go ahead, Bob. Sorry.
One of the things on the clinical measurements and metrics, they don't necessarily have to all be clinical in the pure clinical sense. For example, one of the contracts we negotiated years ago, we negotiated a patient satisfaction survey into the contract where we were required to have an 85% satisfaction approval, if you want to call it that. And the questions were put together by the health center and run by the payer. The payer made some adjustments, but we would have people sitting in the waiting areas with, iPads or whatever, as the patients came out, asking them. There were 7 questions, I believe. And basically the questions range from, how'd you feel about your visit today? Did your doctor pay attention to you? Did you understand what you were being told? By the way, did you have a problem finding a parking spot? How did you feel about the wait time? So it kind of took the patient experience, and it became part of our measures, performance measures, that if we achieved 85% or higher, it would be part of our reward from the payer. So it's not just about strictly clinical. And I think last session we touched on this a little bit, that there's a coming trend to utilize more of this, measuring the patient experience. So keep that in mind too when you're looking at it.
There you go. Next slide. So this is, a follow-on to that, which is the payer-provider transparency. So if you're going to ask to be, to be at the table early on in these discussions, you also need to be able to be willing to share your data with the payer. If you're going to go to them and, after the fact and say, we're getting killed in this program, look at our costs. Well, those are costs hopefully you understood before, and you want to be able to demonstrate that, provide that to these payers. So again, it's in order for you to get paid at what you want to get paid, you've got to demonstrate that A, the outcomes, but B, the costs associated with those outcomes. So that requires transparency. You can't circle wagons around your data. It's really important that you make this available to everyone on the reimbursement side. Next slide. And then finally, obviously, it's really important that you have the clinicians and the clinical departments involved. Not just on the procedures they're going to undertake and the costing, but that you can understand the evidence-based practices that they're using, and that you're able to communicate that to your payers. And that may require that you have clinicians involved in the negotiations with your MCO or your ACO, which may not be your typical way of doing things, right? You may have done that at the administrative level. It's important that now you're bringing in your clinicians so that everyone's on board, that whatever it is you are agreeing to, you want to get those rewards, and you got to make sure you can actually get there. And be obvious and be aware that this is a multi-year effort. You're not going to be in these MCOs for just a year, hopefully. Now, what can happen over time is that they can change the goalposts a little bit based on how they're being paid. They may change some of those metrics a little bit. That's it's one of the wrinkles that's being ironed out in this whole industry, is trying to figure out what are the most effective and important metrics. But no two payers may agree on that. So if you're in several of these MCOs for different populations, you may be doing these negotiations with several groups and over slightly different metrics. So keep that in mind.
One of the things about this is trying to make sure that you have the same metrics, that you can use it year on year. One of the things we ran into early on was we'd do something for 1 year and then the payer would say, okay, that was great, let's do something else. But 1 year wasn't enough to really see if you made an improvement. Once we started bringing our chief medical officer into the discussions and into the negotiations, we were able to put more influence on, well, if you're going to measure asthmatic patients and have that as part of our pay performance, you got to look at it over 24 months or 36 months, not 12. If you're going to do this, you got to look at it this way in time. So making sure that you can influence the amount of time they're going to put onto these, I think is very important as well. And that's where the chief medical officer input was very helpful to us in the negotiation process.
That's right. And, here you are. We're in the productivity world. We're always driving these physicians and providers to be more efficient. But you've got to be able to demonstrate to them that you've got programs in place for that to achieve the outcomes. So if they can hand off that patient to someone else in the clinic for specific assistance, that's gonna make more sense in their head that you want them only seeing the patient for 15 minutes, but they don't have to do it all in 15 minutes. So that's part of that. Just keeping everyone who's involved in patient care happy and on the same page with you as you negotiate this MCO puzzle, if you will. Next slide. All right. So it's really important, though, to appreciate that not all of these negotiations, and I think we mentioned this, are external. You need to sell this, in a sense, to internal parties right off the bat, because they're obviously going to make this work or not make it work at the patient level. And Bob, if you've had some experience with some of this directly, especially in how you communicate between management and your providers.
Yeah, we had the pushback that you would expect, from the clinical side. Well, you're measuring everything we do. We're under the microscope, and you know all about us. We don't know anything what you're doing. So if this whole slide kind of basically says you need to have everybody involved. The clinical side has to know why you're measuring them and why you're looking at these things. I think on the management side, one of the biggest pushbacks we ever got was, well, how do we know what you're doing on overhead? How do we know what patient accounts is doing? And how do we know that you don't have too many people in patient accounts, therefore our overcharges are too high? So we developed a weekly report that went out to every employee in the health center that basically said, here's what happened last week in visits, and here's how we stand on our clinical metrics, and here's how we stand on our other metrics. Are we collecting 90% of our payments like we said we would? Are we seeing the people we said we would? So we did that every week. And then every month we went out to the sites and I presented to them their site's performance and how all the overhead impacted that. So we had a more of a total buy-in that everybody knew why we were measuring, what was being measured, and why it was important, and that everybody was being measured, right down to the facility guy. How many times do we clean the restrooms every day, and why is that important to patient care? So it does have to be that big and that tight a knit of a, if you want to call it, advertising campaign to make all this work.
And you might, we caught ourselves here in this third paragraph where we talk about make sure that the overhead number gets as much scrutiny as the clinical time or clinical cost does. And in our examples, we just kind of use a flatline number for lack of space, I think. But technically, we should be breaking that overhead number down and make sure everyone understands how it applies, because not all those costs may apply to every type of visit, and there may be a variable overhead allocation that you're going to want to calculate. And it shows that you're willing to have your numbers looked at, just like you're getting in and looking at those clinical numbers.
You know, we showed everybody in the organization, and particularly the clinical side, we showed in detail how much was the finance department costing, how much was patient accounts costing, how much was admin costing, how much was operations costing. And then we showed it in FTEs, and we showed it the total cost and a percent of the total cost. And we also, in our cost per visit calculation, we shared that with everybody, showing them, here's how we're showing you cost per year. Here's the provider cost, here's the clinical support cost, here's the overhead cost. Behind that is all this detail. So we were very, very transparent, because we found that you had to be to get that total buy-in.
That's right. Okay, we have just 5 minutes left. I think there are 3 more slides. Chloe, you want to move on to the next one?
Yes,
and we're
and
finishing up. Oh, yes.
Reminder: if you have any questions, feel free to ask throughout the go to chat box on the right side of the webinar too. If any.
Great, thanks, Chloe. So these last 3 slides have to do with this Medicare Primary Care First program that CMS has introduced. And this may not be new to anybody out there. Maybe you saw this coming and considered applying. I think the application window is closed, but it hasn't even actually started. It's going to be, they're just now in the development phase, and they've got who they want to be participating in it. It's kind of the next level up from Comprehensive Primary Care Plus, which is a different model that they were focusing on, and if you ever look at the map, it's quite interesting. There's concentrations of providers around the country who've gotten into that model. Certain geographies, there's a lot of them, and certain geographies, there's none of them. So anyway, this is a program that's going to be, as I say, in the Medicare program, but it's really the next level up for a public payer to be bringing in value-based payment options and focus. But the really interesting part here is that they're, the patient attribution, they're focusing on seriously ill patients. And so this is that, what we used to call high flyers, or there's a bunch of different names for the folks who cost the system a lot of money. It's a relatively small number of patients as a percentage of the population, but the costs that they incur are disproportionately high. And they want to focus on those people, which makes sense. And they want you to be rewarded for actually dealing with their complex issues, and so that you want to get those patients, right? That's a different kind of premise, that you could be adequately rewarded if you can demonstrate your costs and get at sufficient reimbursement to cover the cost of actually getting these people the services that they need. And it's complicated and it's time consuming, but that's kind of where the core of the problem in our healthcare system as a whole from a cost perspective is, right? And that's, the payers, that's what they've got in their mind is cost control. You have more of an issue with keeping your doors open, but also the outcome, patient outcomes. So this is where we're starting to get to that point where those two interests are meeting here. Next slide. So as Bob was talking about earlier, some of the measures are going to be a patient experience care survey. So, if you're not using one of those, you might want to start looking at examples. And I'm sure most of you do use it on some level, but this could actually become part of the, how you get measured and whether you get paid. And then there's the other, in this case, the standard chronic care measurements for, hemoglobin and then your colorectal cancer screening, et cetera. But also that you are putting in advanced care plans with these people. So, which includes all kinds of elements. How are you helping these people comply with the health advice you're giving them, if you will? And are they getting enough contacts, outside of the clinic with health people? So it's community health workers or et cetera, to make sure that they're taking their meds, that they have the meds, they can afford the meds, and they stay on them. And a lot of this is just, you showing an interest in your patients in their regular everyday life. And so it's going to be interesting. Next slide, I think, is the last one. So this is going to be two payments, a population-based payment, a PMPM, and then there's an upside-downside risk involved. And I brought this in because of that small downside risk, 10% of that reimbursements to revenue. That's a first that I'm aware of that they're really seriously talking about it. And it's been a long time coming, but this is effectively how you close the loop and make this value-based system work, or it doesn't work, right? Or as those of you who have been in the industry a lot longer than I have, I'm sure, and I've been around for 16 years, know we've gone through these cycles of what's going to be the next biggest thing, right? What's going to bend the curve and what's going to help our patients. And value-based payments is currently that's the hot button issue. I don't know that what the next one would be, short of nationalized healthcare, but since we're not going to go there anytime soon, this is probably where we're going to end up. Is where a substantial upside and potentially a substantial downside as well. But focusing on patient outcomes and getting to the point where you can work in that world, you've got to know what your costs are so that you can fine-tune that provision of services to these patient groups that you've established. Bob, any parting words? It's right spot on 1 hour.
Yeah, I think all I would say is that we've gone through a lot of material in these 4 sessions. The message I would leave you with, though, is that everything we've shown you and everything we were suggesting starts with the very basic understanding your cost. You have to know your costs better than anybody else knows them. You have to have the ability to do that. And you have to be able to look at these special programs and isolate them on your general ledger and then your EHR so that this data is readily available and it's real data. You can actually go to a patient, oh, this is real, this actually happened. So it's about that. If you go back and look at sessions 1 and 2, that's for the groundwork that sets for this. And then whatever the payers throw at you, if you have that, you can handle anything they want to throw at you.
And it gets back to one of your earliest comments about the nonprofit status of health centers, and that this is, you are going to have mission and money, if you will, trade-offs, but you need to really understand what those are by understanding your costs.
And I know that this was a cost-centered series of webinars, so it was probably heavy on the finance side. But at the end of the day, one of the things I learned that Dave's referring to was at a NAC conference where one of the presenters said, not-for-profit is a tax status, not a health center business objective. So that's right. It's not crass or it's not wrong to talk about surpluses and having income to reinvest. And health centers have been notoriously weak over the years in understanding their costs and measuring their costs. I think it's kind of a new mode to think into. And mission versus margin is very valid, but the mission for the finance people in a health center should be to make the health center be around 25 years from now to keep living out the mission of the clinical side. So we got to work together. Everything we looked at here, the clinical measures and measuring costs and making sure that we're in the kind of service lines we should be in is critical to us being here for the long haul. So hopefully that's what we tried to help you out with these last 4 sessions.
Yeah, and I apologize, I missed this last slide. You can read through it yourself. It's basically just a summarization of recommendations for payer negotiations. But our hour is up. If you have questions, we've been trying to be diligent in answering them online, getting back to you. So if you put in your contact information and have a question, feel free to do it now after the session, and we'll, one of us will, or both of us will be sure to get back to you.
Thanks, Bob and Dave. And I also, we do have one question that came in, and I just want to ask that. Did you come across any risk-based contracts used by FQHCs?
Pure risk?
Better.
No, I haven't seen any, other than in the ACO world. The ACOs have risk-based contracts with Medicaid, whatever, but how that gets passed down to the ACO members is not quite clear. But I haven't seen any pure risk contracts, at least in my experience with the health centers I've worked with.
Yeah, I think there are 2 states where the ACOs have gotten to that level. I know Oregon's one of them. And if that, I'll do a little bit of research and get back to that questioner if they can, identify themselves with their email address, and we'll respond to that after this.
Okay.
Thank you so much, Bob and Dave, and thank you all for joining us. After you close out the session, you will be directed to a very brief survey, and we do appreciate any feedback that you're able to provide. And again, thank you for attending today's presentation and look forward to joining us for future presentations. Thank you.
Thanks, everyone.